A hearty good
Namaste.
afternoon to everyone, and welcome to our session on the topic of male infertility. We are pleased to have Dr. Meenal Chidgupkar from Apollo Fertility Solapur among us to educate us and to share some light on the topic. With her immense experience as the chief IVF consultant, she's the best person to shed some light on the topic. Doctor, you have the stage.
Thank you so much. Namaste. I'm Dr. Meenal Chidgupkar from Apollo Fertility, Solapur. Today we are discussing a very important topic of male infertility. So, since ages, it was all the time the burden on women that the infertility is because of majority of the infertility is because of females. But now it is proven with time and with science that almost 50% cases of infertility are due to male factor, maybe directly causing it or with association with female factors. So nowadays it is very important to have a complete understanding of male factor and male infertility. And as we say in Apollo Fertility, whenever we call patients, we always call couple together like male and female, and we check all the investigation of both male and female to understand what is the cause of the infertility. So basically, there is one concept called fertility quotient. That is the what is this fertility quotient? It is the ability of the couple to have babies. So it depends on many factors. It depends upon the age of the male, age of female, the period of infertility. Then we have to check certain investigations, male, and certain investigation, females. Some hormonal investigations of females, and we have to check bilateral tubes of the females if they are patent or not. And then we come to a certain conclusion whether this couple is going to have baby in the future, or there has to be some interventions done before having the baby. So this fertility quotient is calculated, the complete evaluation, complete history is taken, and we give them advices. So when the fertility quotient is negative, certain problem is there, then we advise them accordingly. But when the fertility quotient is positive, everything is okay, but still there are some problems, that kind of infertility is called as unexplained infertility. Now we'll come on the male factor. When we take the history, the way we take history of female patient, we have to take the complete evaluation of male patients. Sometimes we have andrologists, that is the specialist for the male infertility evaluation doctors with us, and we also are trained in this male infertility evaluation. So international consensus, what they say, so American consensus and urological consensus, European, they are saying when we are discussing about infertility, there are three important things we have to check. First, we have to take a detailed history. Then we have to do investigations, both male, female. And third and very important parameter is semen analysis. Now, the semen analysis, a very crucial thing and the first step. Usually what happens in smaller villages or in places where men don't come to infertility clinics initially, the woman comes, she gets treated, she gets investigated, she gets all the advice, and at the last when male comes and we do his investigations, we understand, oh, the problem was with males. So now the trend is changing. Even the males are understanding there are in it is a 50-50% thing. Having baby is not only woman decides, it is the couple decides. So it is a 50-50 thing, that 50% of the male genes will come, 50% of female genes will come. So the responsibility also of this infertility has to be taken by both, 50-50%. So what I am telling you, that when these patients used to come to us, like initially when they were not aware, they used to come very late, and they used to like shout at us, and then they sometimes used to say ki, what is the problem with me. Sometimes it would have been a second marriage, and that man had previous children, so he was thinking there must not be any problem with him. And sometimes there is a second marriage, even the first female is also not having baby, and now also she is not having, but the male is not getting tested. It is not right. So the first and foremost investigation which we would suggest in infertility evaluation is semen analysis. But the semen analysis has to be done according to the latest WHO criteria. If we study throughout India what is happening with the semen analysis, is the semen analysis is being done in the laboratories which are not regulated. They are done in the older WHO standards. They are done with no standards. They are done by the technicians. They are done after so many hours of giving this semen. So there are a lot of flaws. We have to create a like similar report system, so that what will happen, this semen analysis will be evaluated at different places, but they are comparable. So in such situations I would suggest all labs have to follow latest WHO criteria, WHO 2000 criteria, and even in 2020 there are some modifications, some additions have come, and accordingly we have to change our reporting protocols and give the reports in a standardized manner, so that every center will have a standard report to check with. But is that one report is enough for this semen analysis? No. We have to do this semen analysis in a gap of minimum gap of 1 month, 2 investigations to be done to understand if it is like proper. So even if it is like azoospermia, very bad sperm counts, still we have to understand by doing a second semen analysis, and then we can confirm. Now with this semen analysis report, what we are checking in this semen analysis, there are certain appearance based things and certain quality based things. So the appearance based things, we see what is the volume. So volume of this like semen analysis के टाइम में कितना वॉल्यूम मिलता है, दैट इज अ वेरी इंपॉर्टेंट थिंग. अप्रोक्सीमेटली 1.5 ml तक तो वॉल्यूम आना चाहिए. देन द विस्कोसिटी, द pH, then the concentration of the sperms, the count of the sperm count, then the motility, then we have to see the morphology, morphological forms, वो हेड फॉर्म कैसा है, वो टेल फॉर्म कैसा है, वो मिडिल पार्ट कैसा है, वो सारी चीजें प्रॉपरली लैब में चेक की जानी चाहिए. Like andrologist or embryologist would take the responsibility to give the perfect semen analysis reports. And also a very important thing is the vitality of that sperm. Sometimes we usually give like 30 to 45 minutes after for that liquefaction to happen, and then we check the further parameters. But if we keep that sperm uh, sample for some time, semen sample for some time, then and we check it again, and if we see all the sperms are dead, so the vitality of the sperm is bad in that case. So we have to check the vitality also. There are different methods of checking vitality, like 24 hours के बाद भी vitality check कर सकते हैं, 72 hours के बाद. But usually vitality करके एक understanding भी important है, क्योंकि even in ICSI, which is the highest IVF test tube baby procedure, उनमें भी if the sperm is not vital, then the results will not come. So it is very important to know the vitality of that semen sample. And also the total motile sperm count is very important, and which is calculated in the lab, and that decides what is to be done with that couple. Is the normal cycle is possible, like only stimulation and then natural intercourse, or we need to have the IUI, we need to do IUIs, or we have to go for IVF, or we have to go for ICSI. So all this is decided by this simple semen analysis technique. Now, after this semen analysis, what else is there with the male to investigate? First, for the males, we have to investigate totally their prior history. Like if there are any mumps or cultus or any viral infection in childhood, then if uh, there are any radiation exposure, where he is working, what condition he is working. You have to check the status of male genitals to see the sizes of the genital organs, are they correct, or if there are any genetic problems in their family, we have to check that. Then after, if the volume is less, we have to see that. Then if it is associated with urinary tract infections, prostatitis, that we have to check. And we have to understand what is the semen analysis. And in that semen analysis, if we get azoospermia or oligoteratozoospermia, we have to be very careful that how we have to go about this. Usually the problems with the males may be pre-testicular, testicular, or post-testicular. But for the understanding purposes, we consider this azoospermia into two types: non-obstructive azoospermia or obstructive azoospermia. In obstructive azoospermia, there is production of the sperms in the testis, but there is obstruction somewhere which is not letting these sperms come out. And non-obstructive azoospermia is, the problem is with the production of this sperm. There may be problem with the testis. There may be problem with the higher centers such as hypothalamus, and that is not letting this testis prepare sperms. So we have to understand all these things. So how we'll understand all these factor is by investigating hormonal investigations to be done for the male partner. In the hormonal investigations, we check their serum FSH, serum LH, testosterone, and prolactin. So, according to these values, we get to know if the problem is with the central thing, or the problem is at the testis, or the problem is post testicular obstruction types. So, after understanding this problem, we have to come to a conclusion whether we are going, how we are going to sort this problem out. Sometimes we need to see the scrotal dopplers also when we see some varicosities externally also, and we have to understand which grade varicosities are there and are they treatable. Is that treating varicocele will give any improvement in their semen count, so sperm counts. So we have to see the scrotal dopplers also. Certain times when in some cases of azoospermia, there is retrograde ejaculation, that the sperms are there but the direction is reverse, and we get sperm in the urine. And even in the azoospermia patients, still we do centrifugation and confirm there is no sperm in centrifuge. Till that time, we should not label that patient as azoospermia. So there are different factors. There are certain genetic factors also which are responsible for this gonadal failure, and the sperms are not formed properly. So there can be Y chromosome microdeletion. There can be cis chromosomal abnormalities, Klinefelter syndrome. There is congenital bilateral ductus deferens obstruction. There are so many factors, and we have to understand that. So whenever there is azoospermia or very, very low sperm counts, like if it's less than 1 million, in certain centers it is advisable. So some centers say it is advisable or it is mandatory. And if it is less than 5 million sperm count, it is advisable you go and do Y chromosome microdeletion analysis. So all these tests will be told to you by your doctor, and with the all the researches which are happening, and you have to follow that and come to certain conclusions. Because when the genetic problem is there with you, there is a chance that you are spreading the genetic mutations in the next generation also. So these tests are very, very important nowadays. Now, with all these genetic problems, then with the testicular problems, certain times the radiation exposure or the working in chemical companies and post cancer patients, so when the radiotherapy is given to them in the pelvic area, there is a chance that these testes are involved and the scarring of the testes happen and they cannot form the sperms later on. So what we suggest is, before giving any chemotherapy or radiotherapy in cancer patients, if they are in the age of reproduction, they have to store their sperms beforehand to avoid such kind of radiation exposure on the testes, and in the future if it is impossible to have their own baby. So nowadays there are many people are coming, there's a lot of awareness happening everywhere, and people are coming asking us in the IRT centers and getting their sperms stored. There are few cases, like 7-8 cases in Solapur centers also, where the cancer patients have kept their semen sample stored for their future pregnancy. Now, the testicular thing, like if there is a problem with radiation, chemotherapy, then some chemicals problem, then uh, the problem with the descent of testes, and that has caused the other problems. So all these things we have to examine and understand. Then we have to see where the block is there, the varicocele, if there are grade 3, grade 4 varicocele and causing obstruction, that also may lead to problems, and very less sperm count or the azoospermia. Now, with all newer things, it is possible that even azoospermic patients can have their own babies. How? Usually azoospermic patients, we have to test it is obstructive or non-obstructive azoospermia. Usually in obstructive azoospermia, as I told you, the sperm preparation is there in the testis. But in non-obstructive azoospermia also, there are focal areas of sperm production. So in from that area, we can retrieve sperms with the help of microtesting. So there are a method, testicular sperm extraction, testicular sperm aspiration, and with all these methods, or the actual biopsy of the testis is taken, and from that the sperms are retrieved, and those sperms can be used for the ICSI procedure, which is happening in the test tube baby centers. And we have given many babies with this TISA ICSI procedure, because basically everyone wants their own baby. Even if like azoospermia patients, when we are doing IUI, there we have to use donor sample, and even IUI success rate is 10 to 15%. But this TISA ICSI, when that husband's own sperm can be used, are preferred uh, like treatment protocol here, because here when the male person wants their own baby, their own progeny uh, to have in the next generation. So this way they further go ahead with this TISA ICSI procedure and have their babies. Now certain cases when uh, when we get the TISA sample and we check for the good semen, good sperm quality, and then we go ahead and do the procedure. Certain cases means recurrent implantation, recurrent IVF failure, recurrent IUI failure, uh, unexplained infertility, age more than 35, 39 years, and certain other cases when we see the history of the patients, and certain times multiple pregnancy loss in the past, we have to check the quality of the sperm also. So how the quality of the sperm is checked? Quality of the sperm is checked with the DNA fragmentation index. In that DNA fragmentation index, we see how much percentage of the sperms are in good conditions. So if that person and bad condition, when the percentage comes more and more, that this fragmentation is happening more. So with this bad DNA fragmentation, can we have babies? Usually in our center we have a cutoff of 25%. So if it is less than 25%, we ask them to go ahead with natural or IUI methods. But if it is going beyond 25%, we treat them for 2 to 3 months with antioxidants, check again, and if it is persistently high, we advise them for IVF. Because even in this IUI, when this DNA fragmentation index is really very high, it is very difficult to get the pregnancy. So we do this DNA fragmentation index and make these people understand that there's some sperm factors also which are responsible for not having baby. So with analysis of everything, and very important thing is like this hormonal factors and this diabetes, hypertension, obesity, and drug abuse, alcohol, cigarette smoking. All these factors are also equally important, and they are very bad for the sperm. They actually kill the sperm. So if these people have such kinds of problems, they have to get it treated. So diabetes has to be treated first before going to any procedure. Then we have to see if they have any urinary tract infection, prostatitis, and other infections, inflammations that are causing any problems. If in the semen analysis we get many pus cells, we have to culture the sperm, because whenever we are using this sperm for the IUI also preparation or IVF ICSI, if and we are storing the sperms, if it has microorganism, it would kill all the sperm inside. So that way we have to check other parameters also. So with all these, there are so many things to tell about this male infertility, and it is not a similar protocol for everyone. So for every patient it is different, every couple it is different. It has to be discussed with those people. They have to understand in what directions they have to go. The way we tell diet, pre-IVF diet to females, the similar way we give pre-IVF diet to males also. Because as I told in the starting itself, it is a 50-50% from both of them. So they both have to be perfect before any IVF procedures to be done. So exercise, diet, regular sleep, less stress, all these are important before we should be progressing towards IVF or ICSI. So with all these things, I really want to ask you, if you have any questions, I would like to answer those questions. Or otherwise I will give you some take home message to understand, and whenever you go next time to your doctor, or whenever you come to us in Apollo Fertility Solapur, you need to ask to your doctors. Okay, so I'm waiting for your questions. So if you are uh, really interested to ask anything, you can go ahead and ask. So, for a take-home message to all my listeners, I have just jotted down few points. I would tell you that 50% of the infertile couples have male partner defect. 20% male partner defect is due to azoospermia. So the classification of azoospermia can be, which I told you, it's pre-testicular, testicular, or post-testicular. For understanding purpose, we have made it like non-obstructive and obstructive azoospermia. Low volume sperm count is also important, and the doctor will explain you what are the points regarding that. Then we have to do different investigations. And one point I just wanted to clear it out: before doing any semen analysis, we have to undergo a viral marker tests also, because when this viruses can spread from one person to another person through this semen also. So it has to be for the doctor's safety and understanding of your viral markers. It is very important that you should go through that viral marker testing. Then after that, the investigations, which I had told you, that has to be done. Sometimes testicular biopsy is also important. Then tessa has come in a very uh, advanced way, and that has given pregnancy to many patients. And for infertility, where these azoospermic males are treated frequently in the ART, male factor is very common when we are taking the decision of ICSI. Then there are surgical treatments also, but sometimes those surgical treatments are important for the infertility or important for that patient, that has to be checked, and accordingly decisions has to be taken. And medical management has very important role, but it has to be discussed with the patient, and the severity of the problem and years of marriage and the age of the patient, all factors are to be taken into consideration and then given the treatment. 3 to 6 months treatment is medical treatment is important. Not only 1 month treatment will give results. The chromosomal analysis is important when it's to be told. And if the genetic problem has understood, there are different ways to get uh, to know if this genetic problem has come in the embryos with the PGD, PGS, PGTA, and all these things are very important, and male factor has very important role in infertility evaluation. So I hope today I'm able to give you some information regarding this male factor. And all males, now gear up, understand what is your fertility quotient, and uh, definitely you all will have babies with this new era of advances in infertility. Thank you. I'm Dr. Meenal Chidgupkar from Apollo Fertility, Solapur. Namaste.